So I'd like to welcome you all to our wonderful event, and we're about to start. My name's George Leonard Msengi. I'm a recently graduated physician from Tanzania. And thank you so much. Thank you. So you can call me doctor now. And I'm part of the NCD Child Executive Governing Council Board. So to start off, just some quick logistics. As you can see with the cameras, we'll be having some camera recordings. So please try to keep it down, but also during the question and answer session, do not ask the question without the mic being passed on to you. But more than that, we just have some regrets. We were supposed to be with the Permanent Mission who are partnering with our side event, Permanent Mission of Tanzania, but they sent in their regrets. The ambassador has an urgent emerging commitment at the General Assembly that came up actually this morning. So I will not give the opening remarks on behalf of him. But just to proceed with our program, I'm going to call forth Dr. Stefan Peterson, who is the Senior Vice President of Life Support and Global Child Health Programs at the American Academy of Pediatricians. Let's put our hands together for her, please.
Thank you, Dr. George. Good morning, everyone. What a pleasure to be here. What an exciting time for NCDs. I will say it's really been a privilege since I started at the American Academy of Pediatrics just about a year and a half ago to join the work of NCD Child and to learn from all of the great work that's been happening here, and especially from our youth advocates. Yes, absolutely. I've had the privilege to hear George and Maya and several others that are present today give their remarks at various events in Geneva and here in New York. And really, you know, there's nothing more inspirational than hearing the voices of our youth and their passion and their energy for advocacy. And so today, really what I would just like to say is a thank you for all of you for the privilege of hosting the NCD Child Secretariat over the last 5 years. And I would like to next introduce one of the fellows from the American Academy of Pediatrics and also the chair of NCD Child, Dr. Michelle Farmer. Thank you.
Thanks so much, Jana. Good morning, everyone. Good morning. Thank you all for coming. On behalf of NCD Child, I would like to thank our partners for this event. Even though our guest from the United Republic of Tanzania couldn't be here with us, we certainly want to thank them for their partnership, the Permanent Mission of the United Republic of Tanzania to the United Nations. Was a great honor that they were willing to be our partners. I would also like to thank our partners, the American Academy of Pediatrics, the International Pediatric Association, and Plan UK. And we certainly want to also thank the AstraZeneca Young Health Program for being our sponsors. So let's give them all a hand. We appreciate your support, and we realize that without it, we couldn't have that great foundation and the great start that NCD Child has had. We also want to thank all of you for being here with us, because we know that this is a reflection that you, like NCD Child, believes firmly in the rights of all children, from early childhood to early adulthood, for their right to health and to a productive life. So for this event, we have 3 objectives. One is to showcase global progress in the NCD's campaign for prevention and early management of non-communicable diseases, especially those that affect young people. Secondly, we want to discuss new opportunities at global, regional, and national levels, particularly in the context of universal health coverage. We know we don't want to do this alone. What's new? What are our new opportunities? And finally, we want to inspire young people to raise their voices, to speak out in support of NCD's prevention, management, and control worldwide. And for this event, we have 2 young moderators, it's our pleasure to have young people serve as leaders, because this shows that NCD Child is going to walk the talk. First, I'm going to reintroduce Dr. George Msingi. George is from Tanzania, and yes, as of this month, he has completed his medical school education, and he is officially Dr. George Msingi. George has been an inspiration. He began first with his contact with our organization through a young speaker in Dar es Salaam, joined the governing council, and now he's part of our executive committee. And as a physician, I know that he's going to have a bright future. Our second moderator will be Dr. Marie Haarslev, our incoming chair-elect, also an inspiration and very accomplished for a young woman early in her career as a medical doctor in Denmark. Previously, she was the vice president for external affairs and the liaison to the World Health Organization for the International Federation of Medical Students Association, IFMSA. And Marie has been a featured speaker for several NCD Child events, clearly a testimony to her accomplishments and her achievements. And I'm proud to say that Marie will begin some pediatric training at a very distinguished hospital in Denmark. So let's congratulate Marie. And I'd also just want to say that this is an exciting event. This is going to be a time when you'll hear from some real great people who have been some of the most important champions in my mind. And we will start with our co-moderators, Dr. George Msingi and Dr. Marie Haarslev. So thanks again, and I hope you enjoy this event. Thank you.
Thank you so much, Michelle. George and I will be running the show today, so it'll be fun, and thank you so much, everyone, for joining us. It's exciting times for NCDs, and we are really, really honored to welcome our 3 honorees and our 3 speakers. So if you could please join us.
Can I ask our guests and our special speakers to please come up front?
We have Princess Dina Mired, we have Dr. Stefan Peterson, and we have Sir George Alleyne.
Sir George Alleyne.
Requires.
Yeah.
This is Sir George.
Brilliant.
So, because we're going to talk a little bit about your experiences and all of the work that you've been doing, we are going to briefly introduce these speakers and some of their work, their bios. We know that they need no introduction, but we're still just going to tell you a little bit about them and what they've done in the past. So I'll start with Her Royal Highness Princess Dina Mired. She's a global advocate for cancer control and non-communicable diseases, and then she's a mother of a cancer survivor. In 2018, Her Royal Highness was elected as the president of the UICC, the largest cancer fighting organization in the world. Before this, Her Royal Highness served as the Director General of the King Hussein Cancer Foundation for 15 years. So you've been working in this field for a very, very long time. And in 2011, she was the civil society speaker that delivered the keynote at the high-level meeting on NCDs.
To proceed with Sir George Alleyne, I actually asked him, what else I understand? What else can I add towards the long bio that you have here? And he told me when people come, they don't want to hear about all the history that you have to bring, but they want to hear what do you bring, the content. So I'll just mention very briefly, as he had instructed, because Sir George is the Director Emeritus of the Pan-American Health Organization and serves as the Commissioner of the WHO Independent High-Level Commission on NCDs.
My friend.
But I will not talk about that. He has been. I'll not talk about that. He has been made knight by the Queen Elizabeth II. I'll not talk about his history of medical education, or he has achieved the highest royal honorary in the Caribbean. I will not talk about that.
Last but not least, we have Dr. Stefan Peterson, who is the Associate Director of the Program Division and the Chief of Health of UNICEF, and he's been in this role since 2016. And prior to this appointment, Dr. Peterson was the Professor of Global Health at both Uppsala University and at the Global Health Division of the Karolinska Institute in Sweden. He's
And Makerere University, if I may add. That's the most important experience.
The Korean University.
Makerere University in Japan.
Oh, yeah. Okay. You've also implemented and supported supported projects by the Swedish International Development Cooperation Agency, the Gates Foundation, and the European Union. And then he's the co-founder of MSF in Sweden and the CCM Task Force Operations Group. So please welcome them once again.
Marie, let's kick it off.
Let's kick it off. The first question we have is for all three of you. And we'd like to go a little bit back in time and for you to tell us about some of your first jobs. Were they related to children, adolescents, and NCDs? And how did they impact your career and how you ended up where you are now? Maybe we can start with you, Princess Dina.
I'm always the first. It's terrible. I want to copy and paste from those two.
Yeah.
But thank you so much. Actually, I never thought that I would be in the cancer world. Never. It wasn't a career choice. I'm not a doctor. I didn't enter into medicine and so on. So it was never really on the horizon. And actually, I actually studied even something that is not me at all, actually. It's accounting and finance. So not my character, right? In England at the time, I think I was a confused person, didn't know what I wanted to do. I knew what I didn't want to do. And honestly speaking, really, until my son had the cancer, I would never have thought that I will enter this path. And really, it's cancer chose my family and not the other way around. And that's how I entered this. And it's impossible not to when you're a mother of a cancer survivor. It's impossible not to enter the battle.
Yeah. And we're so grateful for you
you.
doing that. It's you're definitely one of the big champions of this. So thank you so much. Stefan?
I joined, it's a job I share with you, although it's not a formal job, but I was active as a medical student in this International Medical Student Association. And so I went for a few exchanges and I spent some time in some hospitals, in some countries. But anyhow, I never quite liked being locked up in a hospital. I hope you will also not like that. Because life is elsewhere. And as my mentor subsequently at Uganda Ministry of Health, Professor Francis Omaswa says, health is made at home, hospitals are for repairs. And the defining moment for me was actually going through IFMSA to Turkey, to a summer school on primary health care. And suddenly I heard all about the primary health care in Alma-Ata at the time, and rational drugs and appropriate technology. And then I met Itai Mupanduki, who was chair of Zimbabwe Medical Student Association. And then we started a student exchange, and I got to go to Zimbabwe at the height of the primary health care and see that. And I haven't looked back.
Yeah.
Get out of the hospital.
Yeah.
That's my advice to you too.
We'll see.
Wow.
Well,
Eventually. So, George?
First of all, thank you very much for inviting me, and I'm honored to be in the presence of these distinguished people. And George, thank you very much. I don't think we need the permanent representative here because you're going to be the next president of Tanzania, right?
yeah.
Thank you.
I've had several incarnations. In my first incarnation, I was a physician, I was a professor of medicine, I was a kidney doctor. And then second incarnation, I left to join the Pan American Health Organization, which is the regional office for the World Health Organization. I eventually became director of that organization. And in that organization, we had the responsibility for assisting the health programs of all the countries of the Americas, from Canada, I was from Canada down to Argentina, all the countries in the Caribbean. And during that period, obviously one has to address all of the health problems of the Americas. And we focused a lot initially on those problems that were immediately soluble. For example, our region was the first region to eliminate poliomyelitis. Our region was the first region to get rid of measles. And our focus in doing this was essentially to concentrate on the people who were doing the job at the country level. That was the critical element of it, I think. And after I left the Pan American Health Organization, I always sort of George, they fired me. That's what Emeritus means. After I left stopped being director, I have devoted the last, in my third incarnation, partly to teaching public health at Johns Hopkins, and partly to addressing what became to me obvious, the emerging scourge. I was the first person, I think, to use the word tsunami of non-communicable diseases. I was gripped by the urgency of the problem, and I was gripped by the apparent apathy about the problem. And also I was gripped by the fact that this problem affected not only the older people, the GRUPs, but it also affected the young people. And I had a hand in the formation of NCD Child, of which I'm very proud, that the idea that young people should be involved in the generation of ideas about NCDs and generating the kind of spirit that the world needs to address the problem of NCDs.
Thanks. Excellent. Obviously, this is the UNGA of the universal health coverage, so we want to just briefly talk to you all about that. If you could, in 2 or 3 sentences, describe what does universal health coverage mean to you, since we know there are so many different ways of seeing it. Stefan?
Okay, I think UHC, let me talk about 2 of the letters. U is for universal, and that actually means everyone. And it does, whoever you are, whatever you're suffering from, wherever you're living. So I think we need to keep that in mind. U is for universal. And H is for health. And it's not for healthcare. And that actually means that we need to go after the determinants. They might be in the food environment, they might be in the physical environment, they might be in the social environment. Are the healthy choices the easy choices? And I think that's the challenge of making UHC and PHC more than healthcare. Because 9 out of 10 times when you discuss it, you only discuss the healthcare. But it's the multi-sectoral determinants and it's the community empowerment that are the crucial parts of this. So H is for health.
H is for health. Yeah. So George?
Yeah, let me start with the first point Stefan made about universal. I believe that one of the aspects that gets left behind is what I describe as progressive universalism. No country can start from tomorrow with everything needed for universal health care. So first of all, there's a progressivity in terms of the population to be covered. And secondly, progressivity in terms of the elements of the essential benefits package. Unless you have an appropriate benefits package, it is all blah, blah, blah. So for me, if you're going to provide care, if you're going to provide coverage, then you have to think of the universality, that it is universal and it has to be progressively universal. Universal doesn't mean absolute. It has a progressive universalism. So for me, those are the financial aspects. Not having people suffer financially also is progressive, but we can talk about that another time. But the 2 most important, and I must say this, one of the things I miss about the political declaration, they are very keen about the progressivity of being progressive in terms of new populations to be covered, another extra billion. When you look at the declaration, they assume that everything is in place on day one. Not true. There has to be a progressive moderation, progressive implementation, progressive amplification of the essential benefits package, which is essential for universal health coverage.
Thank you. Progressive universality. That's really good. Princess Dina?
I totally concur with Sir George, as I always do. That's the thing. He always says the right thing, right? And actually, what I see UHC is, apart from being progressive, I see it as a transformation approach to looking with fresh eyes on the health system. Many of our countries in low and middle income countries, Jordan as well, we know our health systems have long been geared for communicable, and we sort of organically, band-aid solutions here and there. Certainly in Jordan, the refugee problem also exacerbated that. And there comes a point, like when you build a house, you add things here and there and everywhere, and then suddenly you say, you know what? There's no point keep sticking band-aids. Let's demolish it. It's cheaper and better to start fresh, right? And I like this UHC in the sense, sending a message to governments, giving them in a way the allowance. It's okay, have a fresh look, where you are, what's the gaps, what's the essential package. Don't keep just adding whatever. You can't fix something if you just add for what's there. If it's good, keep it. But if it's not good, rethink again, because you really have to rethink again from the patient perspective. We all know it's all verticals, disease specific, body part specific. Like my sister-in-law, she says it's like a butcher's shop. The thigh is taken up by some agency. The arm is by UNICEF. Nobody can touch that. It's very segregated, very siloed. So you can't get away from that. You have to start fresh. So that's one. The other thing is, it is treacherous. It's not something that any country can do just like that. And I'm very privileged to have spoken yesterday. Yesterday we had a great panel, and we had an Indian CEO of the health reform in India. And the how has not been spoken about in this declaration. And I really want to stress on the how, because the how is, he said, they had set up. First of all, there was huge political will and long term. That's key. 2, the Prime Minister asked them to set up a planning commission that all they do, wake in, day in and day out, to really rethink the processes, to make everything seamless again, to also enter, I suppose, political battles with all the resistance, all the other elements in the health system that are used to a certain way and so on. He said 3 years of design to get it right, because you have to get the buy-in from the people, top down, bottoms up, and so on. And this is the same way what Turkey did. Turkey, with their health reform, I really advise you all to read a Lancet article about the health transformation of Turkey, how they went about it. They had to do a transformation team, because what happens in our countries, the health ministries don't have the capacities. Our health ministries are designed, in low and middle income, mine included, only to do operational tasks. I even talked to the health minister. He says, I have no time to think. I'm just meeting people, tasks. They have no time to have a fresh look. In Thailand, their transformation success was because something called policy entrepreneurs. So this is not an easy thing, like Sir George said, like Stefan said. It is a well thought out thing. It has to be transformative, and part of the plan, you can be progressive, because nobody can do that. And then that's how you find the inefficiencies. You have to think of the patient perspective. You have to think of everybody, and it's doable. And it's not a magic wand just like that.
Wow.
But at UNICEF, we actually summarized what is UHC and the how of it. Would you like to hear the summary?
Yes.
Okay,
I mean, you can all help out. It goes like this. U is for universal, H is for health, C is for coverage, and that is UHC. Equity and power to survive and thrive. UHC is built from community and art.
Well done, Stefan.
So I don't know if that can answer the how.
It really does.
Thank you.
So does. But
Wow.
but my how is also good. It's the real life how. I don't think
I think
they're
we
thinking
all got a
happily.
how. And just to clarify, I think people are looking up to the letters. When you started with this, he was not making the letters for UHC, just to be clear. So to move on to the next question, actually, Sir George.
Yeah.
As the former director of PAHO, I believe, speaking of transformation, you've seen a huge transformation in the global agenda, especially in the NCDs. So moving back or dating back to the years that were leading up to the high-level meeting in 2011 on NCDs, What were the barriers that the civil society community had to overcome to bring their agenda at the forefront of the global
Thank you
agenda?
very much, George.
You have to sing.
No. I'm sad when I sing, and those that hear me sing are sadder. I just saw my very good friend Felicia Noel come in. Welcome, Felicia. George, for many of us, the high-level meeting was a momentous moment. It was the climax of the aspiration of a lot of people that at last health would assume its rightful place in the pantheon of world global priorities. It was a momentous moment because it was only the second time that the UN had considered a health issue. First time was AIDS. And for us, the idea that heads of state would be engaged in considering NCDs was a major event, because also it took the issue out of the province of being uniquely a health issue. It was something that heads of state saw that they had an overarching responsibility. But the number of your question, what were the barriers to be overcome? I think some of the barriers to be overcome and how they were overcome really is very relevant to NCD Child. Because the first thing that was clear to many of us was that advocacy was absolutely essential. And when you look at the advocates that were there, there was, of course, some of the heads of government themselves. And I speak very fondly of the importance of the Caribbean heads getting together to articulate a common position. There was advocacy by academia. There was a Lancet group on NCDs, Robert Bigelhole and his wife, Ruth Bonita, who articulated the importance of the issue. There was advocacy by ECOSOC, for example, and there was advocacy by civil society. This was one of the first, I would say, triumphs of the NCD Alliance, out of which the NCD Child was born. And the civil society dedicated itself passionately to proposing that this issue be at the level of heads of government. Princess Dina was there at the conclusion of the civil society meeting that really tried to point out to the world that there was a sense of urgency about the issue. Tried to point out to the world that there was a lack of the outrage that there should be, that this issue was not being dealt with appropriately. I had the good fortune to speak at the conclusion of that meeting, and I never forget pointing out, and I said this especially to the young people. I said, all of us have ideas, and never forget, as I use the expression then, never forget the power of ideas to change the ideation of those in power. And when I finished, I said to those young people, there are three things I wanted you to commit to. One is to communicate. Two is to educate. And three is to agitate.
Great. Absolutely. That's really powerful.
That's very powerful. But speaking of the triumphants, what is the most surprising change over the number of years, since the beginning of the advocacy campaigns until now? What is the most surprising change that you've seen, or a shift that you've seen in the NCD's agenda, global agenda? Yes.
One is, I think the glass is half empty and half full. The change has been an increasing appreciation of the importance of the issue. It is rare now to find declarations in all the major agencies that NCDs are not important. I think the change has been now that we've seen the issue seeded throughout the United Nations, interagency task force. Every agency of the United Nations is seeds of the importance and planning to do something about it. I've seen a change in terms of the recognition of the importance of those persons who live with NCDs is not only a problem of the higher-ups, it is a problem also of the persons who live with NCDs. That I've seen a change in. What I've not seen a change in, and pardon me using the other side of the coin, I've not seen a change yet, and I'd like to speak with that later on, not seen a change yet in the resources allocated for NCDs at the global level. I have not seen NCDs find their rightful place in the discussion on primary health care. I've not seen that happen as yet. And I've not seen a sufficient mobilization of the health workforce universally to address the issue of NCDs. But looking back, a lot has happened. Civil society has grown stronger. NCD Child is no longer a mewling, puking infant. It is, it has grown. So there's a lot of positive. So pardon me addressing some of the negatives, but you know, you get impatient when some of these negatives, which you think can be easily addressed, are not properly addressed.
Well, thank you so much.
You. And this leads very well into the next question that we have for you, Dr. Stefan Peterson. It's, well, the reflections are, we've had 3 high-level meetings on NCDs. We've had several declarations on numerous documents adopted by governments at the WHO that are working on, are focusing on NCDs, their risk factors, the different disease groups. I want to talk to you a little bit about what are the major wins that have happened for children and adolescents over the last, let's say, 10 years, and what frustrates you the most? And honestly, aren't governments still failing us to progress?
I think you are the biggest change. Because 20 years ago, I think you might have been invited in a tokenistic way, but I think even listening to Greta Thunberg yesterday, I think we need to fundamentally change the way we deal with young people now and not have you tokenistically here, but actually listen to you. And I think part of that is the connectivity and the organization and how information flows. And I think that's the biggest change. Power is never given. Power is demanded and taken. And I think it's about you sort of stepping up and taking power and holding us to account.
Yeah, we're trying. Okay. So, but what frustrates you the most right now for children, adolescents, and NCDs?
No, I think we're still at the advocacy stage, and obviously it's about winning this in stages. But this George over here just already alluded to the fact that the advocacy might be there, but the resources are not yet there, and we're not quite mobilized yet. And I was sort of a bit surprised when you invited me back this year again, because I've been advocating for years. But I wanted to do a bit of a commercial and show that we're delivering a bit as well. Because looking back at UNICEF over the last couple of years, we had a champion called Luisa Brumana, who many of you may know, who actually started convincing UNICEF that NCDs is something for children. Because we used to think that it was only for old people, right? So she succeeded with that. And Nina Schwalbe, who's here, carried on this. And actually, last week, we launched program guidance for early life prevention of non-communicable diseases, so it's a programming guidance for NCD prevention that we're sending now to all of our country offices around the world. So we're hoping we actually go from advocacy to programming. Now, but to show you, so that's sort of, it's starting to address some of the frustration. We may not have the resources, we have some of the guidance. Please.
Thank you.
Our nutrition colleagues have also put out the guidance on overweight and obesity in children and adolescents. We are putting out a guidance on adolescent health and well-being, coming back to my earlier point that we can't keep doing sort of the overweight here and the cancer there and the mental health there as your body part analogy, because in young people, these things are less distinct than they might be in older people. It's about too much frozen pizza, too much television, too much social media, a bit of bullying at school, subject to violence, etc. So we need that integrated stuff. And the big thing and it's still being typeset, this is our new guidance on mental health and psychosocial interventions as well. So I'm giving you this to show that we're actually trying to go from advocacy to action. But obviously, particularly in the lack of resources, we need you people around the world actually exerting that pressure and doing a Greta, as it were, in the NCD field.
Yeah. Thank you, Stefan. And I think we all recognize the importance of when UNICEF starts working on something like this and really implements it into their programs. That's where we have great
and I forgot the most important thing. She's sitting there. Can you stand up, Mamke? She's the one doing it here now. So please see Mamke, don't see me.
Thank you so much, Mamke. We really appreciate your work, and we know that we need to bring in those great actors to make it possible. Yeah, Princess.
Can I just follow up on what Stefan said? I think somebody yesterday, I forgot his name, was writing all kinds of books, and he said, you have people, governments, that's what the beauty of the tool of UHC. That's the thing. It's not going to be just about children, women, breast cancer, cervical cancer. It's a system approach. UHCC is calling on all governments to actually fix the system, the processes, like in a factory, how to make it seamless, how to target that customer who's the healthy human being when they are in contact with the health system, how to target them and maximize all the things that you need to tell them at any time they have a connection with the health system. And what he said, something very important. He says, we do UHC not because we are rich, because we are poor. And this is the message for governments. You are going to find efficiencies. You are going to stop duplications. You are going to, the whole point of UHC, the transformative approach, is to remove all the fat and really just have the most efficient system, again, progressively. It's not one magic wand. And this is where I think you will start to see more, the more that UHC is really broken down in this lens and really explained to government. It's not just, beyond the sort of morality of it. And again, somebody else said, Dr. Tedros said in his speech, he said, it's not just UHC, it's not just a moral imperative, it's an economic imperative. The savings, and that's the beauty about the advocacy that really Sir George, Stefan, and others really led when they put the conversation of NCD on the line in 2011. Since then, actually, what we benefited from, I find, it has given us the tools to speak strongly and say, excuse me, we've done the investment case. We've done everything now since 2011. So everything has been ticked. If a finance minister says something, I say, excuse me, it has been proven by top economists that if you spend $1.7 for every person on prevention, early detection, you're going to save $7 back in 2030. Done. So now we have the tools to shut everybody up who wants to really stop our progress. So I think never, and I really learned this, I have to say from Sir George, sometimes we, like he said, the glass is half full or the glass is half empty. It takes time. And really the advocacy, certainly in my country, suddenly the other day, some lady came and she said, I want to start my own NCD chapter. Can you connect me? I said, wow, this is not even, it's happening. People are moving. It takes time. The fact that somebody in the health ministry knows about the acronym NCD, I'm flabbergasted, because in the past, it's all up there, nobody knows about it. So it's happening, it is slow, but that's why I love the UHC. And it's up to all of us actually to break it down in layman terms. What it really means, what's the undertaking, that it's actually a saving mechanism, it is an efficiency, it is a patient perspective, it is equity. This is what needs to be done from a moral and economic. So that's what would be my answer.
Thanks. And we fully understand the importance of advocacy and recognize that. And we wanted actually to talk to you a little bit about being a strong advocate and the parent of a child that has suffered from cancer. How do you think that has impacted and made your advocacy unique?
Absolutely. I think nobody can ever underestimate, whether you are a survivor or a patient of a carer, the fact that you've been through it, really. So all my lens is always from the point of view of the patient. It just, obviously, from the experience that I went through, you know, for example, when I was Director General of the hospital, you know, sometimes doctors, they have their ways. And I say, excuse me, you know, there is a long time, you know, I would bring that to the table. For example, by the time the patient is presenting at the hospital, and then they take a long time to actually then make that first appointment. And I would really fight and say, look, they're going to die of stress before they die of cancer, before that. So I would always bring that point of view of the idea of the playroom. This is not just a luxury thing, you do a playroom for kids. You have to have a play therapist. This is all about also taking care of the mom to have a little bit of break, giving the child something to associate, something good about the hospital. Because doctors at that time, they just thought, oh, it's a nice little thing, you know, it's a token thing. Yeah. They didn't realize it's part and parcel of treatment. Having really good psychotherapists, little things like navigating the system, doing extra explanation about stuff. So it's so important to bring that from the point of view of the patient. And certainly as a mother of a cancer survivor worldwide, I really, you know, when I speak about, it gives me credibility when I speak about the rights of children and the rights of moms to have care for their kids, for diseases that we all know are curable. And I tell people it's really hard up close, being a Director General of the foundation, having seen parents come, you know, what does lack of access really looks like. It's really hard up close when somebody comes with a child from another country, they don't have no money, and they look at you, you know, can I have care? And you're supposed to, you know, somebody has to make a decision to say, yes, of course we will, or somebody will say, sorry, the magic potion is right here, but not for you. Imagine. And it's every time I say it, I get goosebumps. And it's very important. And I think that gives me credibility that I've seen it. It's not just some theory that I have heard about it. I've seen it. And certainly I'm very proud that I tried to do something about it. And at the foundation, first thing we did is we did goodwill funds to get donations to for treatment. Actually, most of our money went for that. It went for building a new hospital, new extension, and mostly for covering people from A to Z. We would spend easily on one person $100,000, $80,000, $30,000, because you can't just give them a little bit, and then, you know, you have to take care of all. And we tried our best. So that's what I feel it brings to the table. Wow. Because you always imagine, what if it happened to you? I wouldn't be able to call myself a mother of a cancer survivor.
Yes, yes. Thank you so much. Dr. Peterson, speaking of goosebumps, it's been 30 years since the Convention of the Rights of the Child. And I think many of us get goosebumps at how much promises have not been fulfilled. But looking at UNICEF, we know you still push forth the agenda. Now we want to understand how UNICEF has evolved in its focus of advocacy over the number of years, over the past decade, let's say.
Well, come November, we'll actually be marking the 30th anniversary. And even tomorrow, I think we're asking heads of state to make commitments towards the Convention on the Rights of the Child. So it's a legal instrument there, and you may have seen yesterday that 15 young people now actually took 5 countries to legal proceedings under the Convention on the Rights of the Child for failure to recognize their right to a sustainable future. So I think it's about using this instrument and making good imaginative use of it. And I think that's really powerful, because I think in many ways when I'm an old timer now, but when the Berlin Wall fell, And I thought I will live in an age of prosperity and we'll actually putting our resources to good use, etc. Never did I imagine we would find ourselves in such times as we are now. And I think pushing the rights perspective and defending the universal human rights and then the rights for children, etc., is essential in general. And I think we need to be imaginative about how we can use those instruments. But secondly, coming back to your more specific question about UNICEF, we used to talk about the mother and the under 5 child as UNICEF, and that's what we're most known for. But under the Convention on the Rights of a Child, you're a child for 2 decades or 18. And it's about extending that scope and actually being challenged now with the same resources to think about 2 decades and that programming and what is it we should be doing and what is it we could be doing. And we heard about the interagency task force of NCDs, etc., where there are already many agencies and trying to figure out what is it that UNICEF can contribute. And I think we've come a bit in thinking around that, and I waved around these various guidelines now. And I think we have a preventative advantage more than a curative one. And I'd like to think about not sort of singling up the adolescent and saying mental health is over there, overweight is over there, etc., but tackling adolescent well-being and going from a singular focus on weight to well-being. So from weight to well-being.
Thank you so much, Dr. Peterson. Going back to Sir George, you like to keep it in threes. Today you told the young people to educate, communicate, and agitate. But you once told me in person that there are 3 successful rules to successful partnerships. And just to mention the mutuality of interest, specificity of purpose, and clear indication of use of resources. So talking about these 3 rules as you keep them in 3, how can this be applied in merging NCDs as an important UHC pillar?
Okay, I wasn't bad at maths, but I always like to count to 3. I wouldn't go into what I told you then about partnerships. Let me go further. Many of us who have thought about how to go forward have not only looked also at how things work in the world, because there's a lot of literature that can support this kind of actions you take. And I'm going to suggest that looking forward, what might happen to accelerate progress in universal health coverage, and specifically NCDs, there are 3 things I'm going to suggest. One, we have learned from better experience, you need to have champions, you need to have political entrepreneurs. And we need to clone Princess Diana.
No, need to clone you.
All the evidence is that things move from generalities to levels where they can be acted upon if things are framed appropriately. It is the framing that is important. And part of that framing process is to have champions and political entrepreneurs. So that is number 1. And I would advise, I like the idea, and I'm enthusiastic idea about political entrepreneurs not coming only with gray hair. Political entrepreneurs can come at all levels, and therefore I applaud the efforts you two and your colleagues are making. Number 1, political entrepreneurs. The second point is to hitch your wagon to a good horse. And let me explain further. When we agonize about the lack of resources at the country level, we know what can be done. How can we get it done? And recently, a group of us have been involved with the World Bank in looking at the aspect of human capital. Human capital is the most important ingredient of a country's wealth, without doubt. How can we link this effort on NCDs to the efforts being made to strengthen human capital at the local level? Some 60 countries now have pledged to work with the World Bank in improving their human capital. It must be within the genius of man and women to find ways of showing how attention to NCDs is critical for your human capital. And we have advanced, and there's a publication you just got, I'll give you a copy, which shows, as you say, without any doubt, that if countries invest in NCDs also at the level of the youth, they will improve their productivity, their competitiveness. That's number 2. Hook your horse to a good wagon, and hook your wagon to a good horse, it's true. And that horse right now is the emphasis and interest at the global level and world capital and human capital. The third is we often get stuck in old paradigms. And there's a paradigm that is emerging that I think is of critical importance for UHC, is the whole area of behavioral economics. How you can move beyond regulation and legislation to nudge populations into different forms of behavior. So the 3 things I'm going to suggest while you look at your watch. One is I used to be a professor of medicine, you have to see what people do. One, you have to have political entrepreneurs.
Yes.
2, make common cause with those persons who are advocating for human capital at the country level. That represents a mega opportunity for NCDs. And 3, look into different areas, different ways in which you may change things. And one of the areas I'm going to say strongly to you young people especially, look at the whole area how people behave, behavioral economics. 3 things only.
Thank you for the 3 things. Now, moving to Your Royal Highness, when we speak of the youth mantra, nothing for us without us, we would want to see the people actually affected by NCDs being part of all this movement. So can you give us examples of how you have prioritized the youth voices over the number of years and how we would not leave the people who are affected by this in the 2030 agenda?
Yeah, thank you. First of all, we're very proud to have, we started at UICC CEO Young Leaders Program, and this is fantastic. And now, you know, every year more and more, it's quadrupling in applications, and I think this is super important. And now we're even working on how to utilize the alumni so that becomes a big force, not just that they are 1 year and it's gone, so that's one. And we have a young leader as a member of the board, so that's another one, similar to what NCD does. And I just want to say it's so important to have oncologists or doctors or what have you, you know, taking, you know, entering the arena of public health, because in developing world, a lot of people only listen to doctors. And in those contexts, at that time, the old-time doctors, they only were thinking about hospitals. That's it. Yes. They were never exposed to the public health system that actually frustrates them. Yeah? So I find it super important what NCD Child is doing, and that what we should all keep doing is to, and that's what UICC is all about, actually. We are talking about the public health system, so that, because that's what frustrates the technicians. That's the whole point. It's not the other way around. And I like that very much, that this is, that's where we need the youth, the patients, the survivors, the doctors, and especially even now at the upcoming Oman Congress in October 2020, we've even added a medical track. And there was some discussion at the board. They said, but we've changed all of that at UICC. First, we were super medical. Then we became more public health because there is the ASCO and the ESMO. And then they realized, I said, but actually, we should have then everybody on the table, because, so we've added a medical track to get also the oncologists, because we also need them to hear the conversation about public health, because half the time they are the ones leading. Nobody listens to the patient. They listen to the doctor. The doctor are still, quote unquote, he's the one you listen to in our kind of countries. So we need them on the table. So we are doing our best to really walk the talk, and I believe in the youth. Like you said, Greta, I mean, my goodness, this 16-year-old, and Swedish, you're very happy about that. Amazing what this young girl, you know, voicing all our frustrations, and it's so fresh and it's so honest. And you know, youth can get away with much more than we can. We become much more careful and we edit our words and so on. So I believe in the youth, and I believe in all of you to really take on our message, amplifying it, and really change the whole course of the medical community, how the lens that they look at.
Thank you.
Yeah, we should do something while we're still youth.
We can get away with this.
Like not getting stuck in a hospital. Did I make my point? Did I?
Yes.
I made my point clear.
I think
right?
we got
your
it.
point.
I think we got it, yeah. So maybe that goes well into it, into this, because actually what we want to ask you is, looking back 25 years when you were young professionals, what would you wish that you knew then that you know now? Stefan, you?
No, you start. I think about it.
No, actually, what I would, you learn this by experience, but I would have told my young self that you have something to say. Because especially, you know, when I'm not a doctor. Again, this whole complex, I'm not a doctor, I'm not this, I'm just a mother of a cancer. No, I have something to say. As a carer, as a patient, as this, whatever my experience counts. And that's what I've told my younger self, to start with that conviction.
You know, I would have said nothing. I would have changed nothing 25 years ago. I look at myself 25 years ago, I think I was in a comfortable space, did what I wanted to do, and I think what the experience I gained then has helped me to do what I do now. So I would have said, so the idea that 25 years ago you would have changed something you wish you had done. No, I don't believe in that. I don't believe in going back and wishing this had happened or that had happened. So my advice to you is to be comfortable in your own skin now and what you're doing now. And 25 years from now, you'll be saying, I'm glad I did what I'm doing now. There's one thing that George has promised me to do. When we met in Geneva a couple of months ago, and this goes back to business of entrepreneurs. He promised me that
1 million tweets.
He promised me that he would guarantee 1 million tweets.
1 million tweets.
1 million tweets.
I hope you're all going to retweet so we reach the millions.
That's
Still in the
right.
hundreds, though.
Now, that is the kind of commitment I like to have. 1 million tweets about NCDs and what can be done about it.
Yeah.
Well done, George.
Thank you.
No, good. It gets easier as you get to listen to these guys, right? But go for social entrepreneurship. I mean, it's not really sort of sitting around waiting for patients to come to you in your field. And luckily, I discovered soon enough that I could follow my conviction, and I didn't have to become a famous specialist in something or other. And so it's okay to go for your conviction. And then I think it's a Danish philosopher, isn't it, who said that you have to live life forwards, but you can only understand it backwards.
Yes, absolutely.
Go for it.
Thank you so much. So we have some time for some questions, but just to reflect on this to every young person in here. So personalize your experience because it counts. And speaking of personalizing it, I think a large number of the young people have the advocacy at the global level. But when you speak of the personal experience, it's what you have in ground, in country level. So what can you be proud of that you're doing at your home ground? I think that is very important because that builds the foundation of scaling this up. After 25 years, you look back and you say, this is where I started, and this is where I am today. And I am proud to say that in Tanzania, for example, we are launching a national program on NCDs, and I've been part of this. We're launching the NCDs week in November. I've been proud to be part of this, so we can all start at somewhere at the ground levels. So we're going to open the audience questions, and please, if you have a question, raise your hand because for recording purposes. So please raise your hand. We're going to take in the question, and the mic will be roved on to you. So questions to the floor.
It's too early in the morning.
It's too early. Yes, we have a question right there. Yes, Dan.
And if you can just introduce yourself before you ask the question, please.
My name is Stanley Zlotkin. I'm from the Sick Kids Hospital for Sick Children in Toronto, the Centre for Global Child Health. First, it was a wonderful panel, great moderators, lovely comments. I enjoyed them all. And Sir George, given the fact that you're talking in threes, I will give the panel 3 questions. And each question should have perhaps 3 different answers. My first question is about progressive UHC. If one is in a country that is just starting universal health coverage, and they agree that it should be a progressive beginning, what would be the 3 top issues that you would include in a UHC program? First question. Second question is, advocacy clearly is hugely important. If I were to say, we can advocate for a few things to start with, because to advocate for everything is too overwhelming, what would be the first 3 things you would advocate for around NCDs? And the third question is, NCD Child clearly cannot do this alone. Who would be the partners that you would suggest NCD Child should have in spreading the word around the world? 3 questions, 3 answers for each question, please. Thank you.
You want me to start? The question you ask about what are the things to include in if you're going to make it progressive. There is no, I'm not dodging the question. The point is there is no fixed answer to that. I tell you why. Because the first thing depends on the epidemiological situation of the countries. The second depends on what the countries can afford. And the best example I know of that is Chile. What are the major problems to be addressed? Second, what is the budget available to allow you to put in place the programs to address these topics? So when we say universal, we say it needs a careful analysis of what are the major health problems in your countries. 2, what is your national budget that you can afford to put into the essential benefits package? Amanda Glasson from the Center for Global Development written an excellent book, What is In and What is Out, to point out what you put into that essential benefits package will depend on what is the situation which you have to deal and what are the resources which you have to apply them. So those 3 things are absolutely essential. And the last point I would make is this. Robert Bigold points out that all countries can't start everything together. And what we have, talk about that, is a schema of which things are easier to do to begin with. So I am very keen on this progressive aspect. There's some things that are easier to do than others. Mm-hmm. So answer 1 is the epidemiological situation of your countries. 2 is the budget available for the essential budgets package. And 3, some plan of the progressive application of this benefits package.
Can I build on that one? Because being Swedish, let me do an IKEA analogy. If you go on IKEA's website, and I'm not sponsored here, there's an IKEA kitchen planner. And I think it applies very well to what we need to do in this space. The first step is that you define the context. What does my kitchen look like? Where is the window? How tall is the wall, etc.? The epidemiological and the health systems context that we just heard described. The second is saying, what are the functions I want in there? I want refrigeration, I want to be able to cook, I want to be able to store, and you can pop in those modules from IKEA thing. And the third one is probably the most important. It's where you press, and out comes the system's requirements. It says so many cupboards, and this thing, and this is where you pick it in this aisle, and this is how you put it together. Because more often than not, we say, I can make a better cooker than you have, and I can add a new function to the cooker, and look at how great this extra added thing to my medical intervention is. But that's only one of the steps, and ultimately it needs to end up in the system's inputs. And they're very few. It's about human resources. it's about financing.
Budget.
Yes.
Don't forget the budget.
Yes. And it's about supply chains, and then it's the whole data piece, sort of. And I think we need to boil all of this down to those systems inputs and not concentrate on an extra function on the cooker.
Your Royal Highness.
Can I just
Yes.
weigh in on that as well? Thank you so much for this question. Again, I go back to Turkey's example because I've really read that article super well. Like now I really feel it's like the how, honestly. If any country, I'm always sending this article because it was such a well-written article of the how. It's the real life how, the trials, the tribulation. Don't forget, in many countries, they actually don't trust their government to offer public, really qualitative public health, okay? They don't trust it. So if you're going to do universal health coverage and to convince the public that you're going to do that, when you still are not ready, you haven't got accredited public health hospitals, you don't have the top oncologists or whatever in those hospitals and so on, you need to win them. And part of the process was, like Dr. Sir George said, they did some quick wins as well. Certainly in Turkey, their main thing was they had such a high mortality of infant death, pregnancy and infant death. So that was the number one thing, how to fix that. And there are some things that take long term. It's not just the budget. Where are the people if they don't have enough oncologists or enough pathologists or enough that? So their program, they had to do something with the higher education. They had to, they looked at it 360%. And that's why it's really designing a complete system that fits the country. Because if they fail, nobody is going to chip in, especially for those countries that require contribution, right? If it's public health, okay. And I know in my country, if you talk to the health minister, they say we cover people. And I can't say no, but does he cover people at top hospitals, quality hospitals? No. They cover some people to a hospital that's only geared for primary care. And yet they send cancer patients there with not one single oncologist there. Do I want to be covered there? No, I don't want to be covered there. So again, the reason why it takes time, and it's very specific, no one size fits all, you need that strategic team. And they've had resistance, he tells you, from the medical community, from the private hospital. And again, you have to engage the private hospital. You can't just, and what's lovely about the Indian and the Turkish model, they gave money to the people so they can choose which hospital to go to, where they feel it has the best. And they gave incentives. You're talking about many things in this UHC. Incentives for private hospitals, how they can regulate them so they can also keep their quality. It's so many points. If you want to do a proper UHC, you have to gain the trust of the public. You have to placate the existing powerhouses that countries have already sort of inherited and so on. It's a political process, economic, it's efficiency, it's process engineering, it's budgetary, it's everything. And that's why it takes time. That's why I hate it when my country, they say, oh, we're going to change things. Let's ask the people in the ministry who have no experience in strategy, don't have the time, and in 2 weeks they want to make a big thing. 2 weeks. Yes. I say, for God's sake. So that's why countries need to know it has to be a serious strategic mind team, a transformation team, or a planning team that's long-term. That takes no less than 1 year to think this through properly, because the fights will be there. It's not easy. And the guy said the word treacherous. It's a treacherous thing before you design a really good plan to fix it. And what's beautiful about the Turkish model also from the Lancet, they said they had even community leaders to feed back to the transformation team. So the information is quick, so they can quickly tweak it. They did they enshrined it in the law. That's another thing, the rights of people. So they empowered the patient's rights to know what to expect. They did they really did the contextual drivers. They prepared the ground for it to be uptaken. It's really comprehensive thinking that needs to be. And the beautiful thing, you can see now different examples from India, from Turkey, from Thailand and others. And I really tell people, those who want to do this, pick up your bag, go to those countries, spend 1 month. It will be like the best, MBA degree you will ever have, and come back and copy and paste. And fine-tune.
Okay, because of time, we're going to ask the audience to give maybe 1 or 2 more questions, where I think you can get more time to clarify on the other 3 from them. So let's take 2 more questions and we'll be done.
So we'll take
One
Mike and
question,
Christina. Yeah, quickly.
Hi,
Sorry,
Jen
Ed.
Williams from Plan UK. Given that 35% or nearly 35% of the global disease burden has its origins in adolescents, how do you think people of all ages and backgrounds can influence their national governments to pay sufficient attention to adolescents within UHC?
Great. I think we'll take the 2 more questions and then we'll see.
You're really testing my memory here.
So there was Mike and Christina. Yeah.
Hi there, my name's Mike Eliash. I'm with the World Medical Association's Junior Doctors Network, and in my day job, I do for my sins work in a hospital, in a neonatal unit, dealing with inotropes, ventilator settings, and all of those kind of things. One of my colleagues on a night shift last week was talking about how they don't care about politics, and that politics isn't their thing.
Politics?
Yes.
Yeah.
And so I was wondering how, as an NCD community and a global health community, we can talk about the issues of politics, of tax, of individual freedom in a better and more articulate way that engages people. In the UK, we've got pushback against our sugar-sweetened beverage tax by our Prime Minister, who's talking about how it is the nanny state and kind of taking away from people's freedom. So how we can talk about those kind of issues.
Thank you. The last question, please.
Good morning, everyone. Also, thank you very much for this discussion. It's early in the morning, as you said, Princess Dina, but it doesn't really, it's no problem. It was very lively. I was thinking when I was sitting here and listening and really enjoying, I was thinking whether I should pull a Greta or not, and also not to be just happy and positive. And I will try to frame it in a way that it fits also in this discussion. But my name is Christina, I represent IRGT International. We are working with development through alcohol prevention. So when we are looking, for example, at UNICEF, and you, Mr. Peterson, you had a very good comment in the beginning that the UHC is not only universal health care, but it's the whole system, and that we also need to address the determinants. And one of those is also commercial determinants of health. And then I am thinking about the alcohol industry, of course, coming with my background here. And I wanted to ask, especially UNICEF, like if we are addressing the whole system, addressing the kids, how is UNICEF also going to look at the corporate literacy of children, and also on the internal policies and conflict of interest of UNICEF, as we were, for example, addressing for some time now that David Beckham is ambassador of UNICEF, at the same time having the whiskey and being really ambassador for whiskey, and at the same time addressing children, which we think that it's a really conflicting thing. But so this is the Greta frustration from my side. Like, how are we? I hope it's. I guess it's very mild compared with Greta. But then I would like to also understand is like the comprehensive approach, as universal healthcare is also the whole comprehensive and systematic approach. How is UNICEF going to address it? Thank you so much.
Peterson,
You're on the hot seat.
Oh, when I still remember the question, let me start there. Thanks. I wasn't aware that David Beckham was advertising whiskey. I think it's a big bad world out there, and much as sort of we like to think about black hats and white hats. I mean, I'm old enough to have seen cowboy movies. It's a world of gray hats. And obviously we'll need these partnerships because it is commercial interests and commercial determinants, both on the good side and the bad side. And so much of what exposes us and also of the solutions obviously require these partnerships. But I think we shouldn't be naive about them. Certainly there's where you can enter in a shared value partnership with public and private and between various public entities for that matter, because you have the same goal. And then there's the ones where you need to sort of dialogue, but you'll never enter a partnership. I mean, vaping, for instance, and tobacco, I mean, and alcohol for that matter. You'll still need to somehow talk to them. And as UNICEF, we put out a couple of months ago, my nutrition colleagues, actually our guidance and position on sugar tax, which, nanny state or not, that's a populist trick, is a very effective policy instrument. So, and at many country levels, we're actually stepping in as UNICEF and facilitating that dialogue. But certainly, you see, if you look back, the tobacco industry playbook from 20 years ago is being played by the sugar industry now. So we try not to be naive about it, but also engaging in a dialogue, if you will, with everyone. But it's your right to be frustrated, and you should hold us to account. I think you can't. Let's acknowledge that everyone has a gray hat. It's only the color that difference. And on the partnership, and several questions to that, and the politics. I think it was already alluded to by Sir George here, sort of on the human capital side. But the other big thing out there now is the sustainability of the planet. And I think sort of the sustainability of the planet is essentially the question about the sustainability of our life conditions as humans. Because we're in the 6th mass extinction now, the 6th mass extinction. And we'll be like the dinosaurs. I mean, I took my daughter to the Natural History Museum and we looked at those dinosaur fossils up there, and I said, well, pretty soon humans will be standing next to them, and then the cockroaches will walk by and say, I wonder what happened to humans. So I think linking up the sustainability of health and environment and climate is a great ally. And for that, you need ordinary people, Stan. And you need ordinary people to go out and demand that this is political. And in addition to sort of linking with ordinary people like that, ordinary young people that is, and I think we've seen many examples now how this can be done. We also need opinion leaders. And I think AstraZeneca is working with you now actually on this Young Leaders program that has brought forward some of you, and we need much more of that. And if there's one thing, which was, coming back to your question about 25 years ago, out of various fortuitous circumstances, I ended up in a public health environment, and I saw examples that I don't have to become a hospital doctor, and I can do a different thing. And the earlier you see that in your career, and not just if you're a medical doctor, etc., the more you're exposed to that kind of thing, the better it is, and you build a network. Because I'm sure your classmates are asking, what is it you're doing in New York now? Why are you not here doing and becoming a surgeon and making money and doing a big, that kind of thing? Yeah. So those are sort of a few ideas on partnerships and making this politics. But politics is ultimately about people getting votes, isn't it? And getting demands. So you need to sort of forge those alliances and get the movement behind you. And it's never been easier or cheaper to get the movement behind you than now. I mean, it's in your pocket.
Yes. Yes. Thank you so much.
I want to put my stake down here for the tertiary care physicians. Don't let us get carried away with this dichotomy about primary care and public health and personal care physicians. Don't. When I have my myocardial infarct, I don't want an epidemiologist looking after me.
No, right? I'll write a nice report about it.
So don't let us make any distinction about good and bad and primary care physicians and public health physicians. But
I think the young physicians in the room are hearing this. But also, can you reach out to any of the questions? Yes.
Yeah, I want to address the question of politics. Yes. I'm going to make it in one flippant and one serious comment.
And give us a closing remark.
When I was a little boy, I did Greek, and my Greek master used to say, a politician comes from polis, a city, a public citizen, and it's the most noble profession in the world to be a politician. And he says, you know what is a Greek for private citizen? Idiotes. I used to say, an idiot is not a person who's mentally defective, one who's not interested in politics. But that is... the answer to your question is this. We must be clear that the political class is the agent and the people are the principal, and the agent is responsible to the principal in contract theory. And many times we let politicians get away with the idea that they are the principal and not the agent. Now, how do you correct this? You correct this because you need to have the principal articulate to the agent that there are certain things need to be done from which they be held accountable. And that is the essential role of civil society. So the role of civil society is to point out what is the account to be rendered, what are the politicians accountable for to the people. That is the essential role. And I would say to your colleague, please get involved with the civil society so that they can articulate clearly what the politicians need to do.
Yes. And Your Royal Highness, can you give us a comment
Yeah,
on any of the
I
questions?
really want to address the politics issue because I've been experiencing it recently and until now with our fight against tobacco in my own country. My own country is very infiltrated in tobacco because like we said, all tobacco industry is focusing on Middle East, Africa, and my country is undergoing a very difficult economic cycle, so they're dangling their dollars. And we've just been, and I saw how the lack of knowledge about the industry tactics in my own country when I first started to fight against tobacco, and people just wanted to be anti-government. They forgot that they are the losers in everything. So I was starting to write articles. I said, you guys, you think you're anti-government, anti-this. May I remind you that the CEO of a tobacco company has, Google it, I say, he gets $5 million minimum of declared salary per annum, goes to the Bahamas, sunbathes and does his exercise and I wrote an article exactly like this. And I said, and that person doesn't even smoke because they know what's in the cigarette. And so if you think you're annoying the government by, you're taking my freedom, may I remind you, you're the loser. You're losing your money. So I realized that that conversation is not there. And how to rectify it, we needed to start changing our methods. Wow. Using social media, going to schools. I'm working with a lot of wonderful, like you said, civil society. We go to school, and you should see the eyes of the kids. And I said, you may think you are choosing the cigarette. Actually, you're not. You are a victim. You are a cash cow. You are part of a conspiracy. You should see their eyes. You see their pupils. And hang on a minute. That doesn't mean adolescents will listen to you. We all know that. We've all had our adolescent children, and they love to just go against what you say at that particular age frame. But we have to change that by actually putting the conversation that everybody is in a pawn of whatever industry, and you have to be smart enough to understand, that this populist answer that's actually propagated by the industry itself, taking off your freedom and so on and so forth. And it takes time, but we are doing it. And I'm very glad because it is an issue. It is an issue.
Thank you so much. So I think we can put our hands together for the amazing panelists that we've been having panel discussion this morning. Thank you so much. And now to invite Dr. Marie to proceed.
I think you should put our hands together for the moderators.
Wonderful moderation.
Marie?
Yeah, just before we close today, I want to announce that NCD Child have just published a new report that is looking into the global burden of disease of NCDs in children, adolescents, and young people. And it's really putting together the data that we have from the Global Burden of Disease study, WHO, and other resources, and looking at how are young people affected by these diseases and how are the risk factors, how prevalent are they, how many deaths are there due to NCDs in these age groups that we're working with. So I very much hope that you'll all have a look into it, and it's going to be at the NCD Child website. And then, because we are seeing these grand speakers as honorees, we have a small token that we'd like to present to you all. So we have first for Dr. Stefan Peterson, we have and I should say it comes from a global art contest that we did last year with adolescents that did some different art pieces, and these were some of the winners. looking into these issues and really showcasing how they see the challenges with NCDs. So this is from a 13-year-old Ifra from India around moving stigma on mental illness.
Thank you so
Thank
much.
you.
And for Sir George, we have this incredible portrayal of the complexities of NCD prevention and control by a 20-year-old Mehak from India also.
Thank you so much, Sir George. Good luck. Thank you so much.
And finally, for Princess Dina, we have this picture from a 17-year-old from Hungary, and that really conveys the world of health for all and what it should look like.
Oh,
Thank you
that's
so
lovely.
much.
Thank you so much. Thank you.
And for those of you that are interested, I believe we have some postcards in the back with exactly
beautiful,
these art pieces. Now we'll just quickly take a picture of us on the stage.
It's happiness, cozy, very cozy, wozy.
So where do you want
Oh, okay, we can stand on
Right
here.
here.
Sure.
I can stand on this side.
Oh, there are so many cameras to look at.
Yeah. Focus on
We
Kieran.
feel like movie stars.
Thank you, everyone.
Thank you. Thank you so much.
Well done, Skipper.
Really
And good luck to
pleasure.
you. Huh?
Thank you so much.
Thank you.
Thank you so much. Honored.
Thank you so much. We hope that you'll continue to work on these important issues with us.